Major support for these broadcasts is provided by the CUNY TV Foundation, New York Community Bank, Chase Commercial Term Lending, Chelsea Lighting, Capital One Bank, Genova Burns, Giantomasi and Webster, Kilroy Architectural Windows, New York's Window Company, the Witkoff Group, Greenberg Traurig, M&T Bank, Perfect Building Maintenance. Additional support is provided by Ackman Ziff Real Estate Group, Bank of America Merrill Lynch, Briarwood Organization, C.B. Richard Ellis, Colliers International New York, Cushman & Wakefield, Dime Savings Bank of Williamsburg, Douglaston Development, Levine Builders, DDG, Friedman LLP, Accountants and Advisors, Flushing Bank, Herrick Feinstein LLP, Investors Bank, James D. Kuhn Real Estate Center at Syracuse University, James Orphanides, Centurion Holdings, John Katsimatidis, Red Apple Group, Corman Communities, a.k.a. Hotels, Madison Realty Capital, Margolin Weiner and Evans, LLP, Certified Public Accountants and Business Advisors, Massey Knackle Realty Services, New Banks, Meridian Capital Group, Newmark Grubb Knight Frank, Popular Community Bank, Sterling & Sterling, SJP Properties, Stonehenge Partners, and These Friends.
(2013), a year of changes. Not a change in presidency, a change in mayors next year, a change all over, change in governors in New Jersey. So, but the big thing is healthcare. Everybody looks at what's happening at healthcare, Obamacare, new hospitals, openings, closings, I don't know. But I brought the gurus, the guys who understand healthcare. No one understands healthcare better than these guys. So my guests today include Michael Dowling, who is the president and CEO of this small little healthcare system, the North Shore-LIJ health system, 15 hospitals, 45,000 employees. And then from New Jersey, really Plainsboro, even though it's called the Princeton healthcare system, Barry Rabner, who's the president and CEO with 214 beds, but a variety of things on 161 acres. And then from the home of the Yankees, the man from the Bronx, who went to medical school in the Bronx, Dr. Stephen Safyer, because if I didn't call him Dr. Stephen, his mother would be unhappy, who is the president and CEO of Montefiore Medical Center. Thanks for all being here today.
It's a pleasure.
So, Stephen, we were talking about insurance companies, that Mr. Dowling wants to be an insurance company, and you said to me you are an insurance company. What do you mean by that?
Well, the insurance world is changing, and Obamacare will accelerate that. And I'm sure we're going to have a lot of time to get into that. But most important response I could give to what you're asking me is that over time we've seen the way we're paid whittled down. So it is important to all of us to get further up on the revenue stream, the premium stream, and use all of those dollars to invest in better health care. I know that Michael and myself view prepayment or capitation as a better approach to care than fee-for-service. Fee-for-service leads to doing more, not necessarily doing better.
So basically, if we keep somebody healthy, you make more money.
Right, so 50%...
Is it risk sharing? I mean, but what happens if the person's really sick and you're only getting X dollars? He has a big overhead. You have a big overhead.
So all upside risk has downside risk, and there's risk in fee-for-service also. But what's nice about prepayment or capitation, and 50% of my revenue is now prepayment, 50% of $3 billion plus dollars, is that you can use the money to invest in wellness programs to keep people out of the hospital. And if you do well at that, you can share in the savings. In the other system, you had to wait till people got sick.
Why are you becoming an insurance company? I mean, I know you're partners with this gentleman in Health First, but why are you now going to be an insurance company and you're going to be going out to companies in your basin over there and saying, okay, you're going to be competing?
Well, it goes back to what Steve said. We've been primarily in the illness business. So if you ask yourself, if you sit back and ask yourself, what do you want to be in? From my perspective, and Steve and I talk about this quite a bit, I want to be in the health promotion business, and I want to be in the illness treatment business. So I want to take care of you so that you stay well. And when you get sick, I want to be expert at taking care of you then. But I want to do the whole thing. And today, and traditionally for decades, we get paid when you get sick and you come to the hospital. And the sicker you are, and the more we do for you when you're sick, the better we do. That's not the right model. We should, if we call ourselves a healthcare system, we should be about health. So what I want to do, and I'm doing, not to the extent that Steve is doing, because he's been at it for quite a while.
He's also in a different population than you have.
Well, my
census-wise.
Well, my population, you know, because I'm geographically broadly dispersed. So I have populations that are pretty in well-to-do areas, and I have populations in relatively poor areas, in relatively rural areas, and in urban areas. So it's very, very mixed. But either way, irrespective of the population that you're dealing with, I want to be in a position of being able to get more of the premium dollar or the full premium dollar, and then being able to make decisions about how I can provide the best care so I can deliver the best outcomes health-wise. That does not mean, and some people think that all hospitals are bad places, and if you're in a hospital, it's a bad thing. Good things happen in hospitals. People's lives are saved in hospitals. We do great things all the time, but you should only be in there where you need to be in there, but you don't need to be in there when you should be treated in another location. I want the flexibility to be able to do this. I don't have that flexibility under the current reimbursement system. The incentives are misaligned. I want to be able to also control the clinical protocols and have the physicians make the decisions about the best way to provide care rather than being over-regulated by everybody from the outside. Now, this doesn't mean, one last point, that we don't do partnerships with insurance companies. So you'll have hybrid models. You'll be doing stuff by yourself, you'll be partnering with insurance companies, and you'll be doing both. Given the market we're in, I think that's the way it's going to end up. And you know, I learned a lot from what Steve has done, because Steve has been one of the more innovative people in this region. And so I learned a lot from what Montefiore does, and we work together quite a lot, Montefiore and Shore-LIJ. So our jobs, as long as we hold them, is to make things better, not be comfortable with the status quo.
Barry, how do you put yourself with these two socialists over here? Okay, socialized medicine, and you're the capitalist, perhaps.
Yeah, I don't know about that, but you know, the issue that we have, and the analogy we use is we have 1 foot on the dock and 1 foot on the boat in terms of how we're reimbursed. So most of the care we deliver is on a fee-for-service basis. So each unit of care we deliver, we get paid for. And these folks are talking about capitation, which I guess in our market is coming, but it really represents a tiny percentage of the care that we deliver. And you know, people should never underestimate how much is determined by how care is delivered is so much determined by how it's paid for. Because you made the comment earlier that you know, you may serve more poorer people or people with better insurance. The difference is in who you're serving, it's how you're being reimbursed. And that goes back, I think, to your point about one of the main things that's wrong with how care is being paid for and therefore how it's being delivered.
But I think, you know, with regard to that reimbursement levels in hospital stays, when Dr. Safyer graduated medical school, people would be in the hospital, you know, for 7 days, 8 days, perhaps, or 14 days.
I discharge heart transplant, children with heart transplants quicker than when I did obstetrics at the Einstein Hospital.
So what's the average stay today in Montefiore in the hospital? I'm talking specifically for hospitalized, because we'll get to ambulatory care in a minute.
5 days. 5 days.
5 days.
Yeah, a little bit less than 5 days, about 4.8, 5 days. I remember in some of the hospitals that became part of our system years ago, I remember having 15-day length of stays. And the people at that time at that hospital thought that was okay.
Now wait
It
a
is
second.
not okay.
But why even 5 days? Because you have this situation with the 23-hour stay. Get rid of somebody.
Because it's an average, and we have very complicated surgeries and reasons to be there. It's an average.
So our length of stay is 4.5 days because on average our patients are less acute than the patients in their hospitals.
Now, but my question, and we were talking about this, you open up a brand new hospital, a major facility, $651 million cost, a large acreage, all single rooms, which we'll get to over there. What type of, what's the idea of changing and opening up new hospitals? You rebuilt a new hospital, and your hospital is constantly under changes and How do we see ambulatory care and what's happening? Because people want, you're not in the hospital anymore. Most of these procedures are done off-site, in different facilities.
Well, well, first of all, on the hospital issue, I mean, most of the hospitals in this region are relatively old hospitals in New York. So I had hospitals going back to the 1930s. 1940s. I mean, you don't typically drive the car you bought in 1940. You don't drive it today. So you have to keep your facilities because you're going to have people in the hospitals. You're going to have a lot of people in the hospitals, not as many as before and not staying as long, but you should have the hospitals that are, provide the right experience with the right kind of privacy, the right kind of quality, etc. But most of our expansion in my system is on the ambulatory side, because so much can be done outside the hospital. And that's also a function of technology, medical advancement, know-how. Imagine how much medicine has changed over the years. Steve can talk to this even better than I. How much medicine has changed since he graduated. The things that you can do today that you couldn't have done when he graduated. And if you were able to do some of the things when he graduated, you did it in the hospital. Today you can do things on the outside. So why should I put you in a large facility in a somewhat impersonal place, no matter how comfortable we try to make it, when it can be done in an outside location. So my expansion primarily is on the ambulatory.
We're 4 months into a construction of a new facility, 300,000 square feet, 12 stories high, ambulatory surgery, procedures, subspecialty care, all kinds of things that we used to do in the hospital will be done there. It's a hospital without a single bed. There's no beds. That's what it is.
Yeah, but what are you doing in the St. Vinny's site?
I'm building an ambulatory site that will
Which is similar to what he's building up in the Bronx?
Yes. I already have a 400,000 square foot location that is almost everything that can be done in the hospital except beds. You don't do transplant, you don't do neurosurgery there, etc. But everything that was in that facility today, and this is huge facility, was 5 years ago done in the hospital. That's not necessary anymore.
And in case there's any complications, you have an ambulance outside, and you send them over
my
to
own
the
ambulance company.
Yes.
in the same way.
Yeah.
Oh, yes.
See, the irony in our market is 20 years ago in New Jersey, there were 147 hospitals. There are now 73. So here we are looking at that and saying, we need to build a replacement hospital. And the idea is, like what you were saying, our building was 93 years old. And then with all the changes in technology, pharmaceuticals, just generally how care is delivered, an aging population in our market, also just a growing population, some other demographic pressures. People still need inpatient care, and the ability to take a virtually 100-year-old facility and change it so that it could meet those conditions is close to impossible. And if you do, it's extremely costly and time-consuming. So you make the investment because it's necessary.
The topic on everybody's tongue today is Obamacare, exchanges, and different things. What effect is that going to have in 2013? Or as you said prior to the show, it's going to take many years before this happens. What do you see?
Well, nationally, I think we're all delighted that we're going to insure 40, 50 million new people. And I think as a country, we can hold our heads up higher when that comes to be. New York and New Jersey are a little bit different than the whole country. I can speak better to New York as Michael can. We insure over 5 million people with Medicaid already. And we have a lot of employer-based insurance, and we have an older population than many other states. So there's a lot of Medicare here. The upside in New York would be coming if there had been immigration reform, or if immigrants would have been allowed to be in Obamacare. The way it was configured, that fell on the cutting floor. So that's an important thing we need to get back to. We need immigration reform. It's not as much upside in the new legislation in places like the Bronx.
How do you see it, Mike?
Well, I agree with Steve. I think that as a country, everybody should have access to care. Well, let me restate that. Everybody should have insurance. The trick will be making sure everybody has access to care, because you have insurance, and that's part of the reason for a lot of delivery reform that needs to be done. But I think Obamacare, it sets up the situation where you can have a lot of demonstrations. It allows you to do a lot of things differently. But I think it's too early to tell as to whether or not a lot of these things will, in the long run, be successful. I think we have an addiction to calling things successful too soon, and I don't like to over-promise. I'd rather over-deliver and under-promise rather than the other way around. I think the expectation has been set very, very high, and that might be a mistake in the long run, because some of the things will fail, some of the things will work, and many of us are involved in a lot of demonstrations. It will take a period of time to figure out the winners and the losers here.
Here is a very interesting situation. Someone becomes eligible for Medicare, myself, and you want to go to certain doctors, and they say, I don't accept you. I mean, I've been paying insurance, Medicare was created, and I want to go perhaps to the hospital for special surgery, but I don't have surgery over there. I want to go to certain places, and they say, you're not covered. Isn't that incorrect? Isn't that against what you've been saying?
Every physician at Montefiore takes Medicare and Medicaid.
What about at your?
Well, the physicians, private physicians that work out in the community as private entrepreneurs in their own practices, many of them don't take Medicare. Some don't take Medicaid. They are concerned about the bureaucratic hassle, about the level of payment.
I believe it's mostly the level of payment more than the bureaucratic hassle.
So this just is another one of those complexities. This is why I said just because you do something legislative-wise doesn't necessarily mean it all translates into seamless implementation at the ground level. All of these things will have to be addressed over time, and I believe that they will. You know, it's funny, it's interesting, years and years ago when Medicare started, most doctors opposed it. Then all of a sudden they found out that after a while, they found out it was one of the greatest benefits to them. But when you read the newspapers these days, the reduction in the reimbursement, and this is something that all of us are concerned about. Remember, we have a second iteration, you could say, of Obamacare about to happen as part of the fiscal cliff debate, when there is another $400 or $500 billion of cuts for doctors and hospitals.
Right, and then you have some surcharge on medical devices, I believe, coming.
And there's a 2% surcharge on medical devices, and all of those things. There's a reason for a lot of these things, and logic. Some people would argue for why all of these things could happen, but there is a point by which if you keep cutting and cutting and cutting, it will eventually have a negative effect.
Now,
that's why you got to get away from the reimbursement the way we've traditionally.
No, that's why you're trying to get the capitation and keep somebody healthy.
Right.
Now, here's another question with regard to 25 years ago, how many practices were owned by hospitals? You're saying today nearly everything, all the doctors work for you.
So
not you have a third, and you have a small amount.
The majority work for us, but let me go back to something Michael said, and I think it's important in understanding Obamacare. In crafting the legislation, there were noble ideals. So insure more people, change the reimbursement system, and create delivery systems that are not fragmented, that are integrated. You need all three things to be transformative. It was strong on insuring more people, not particularly for New York. It was weaker on changing the payment mechanisms and the delivery system. So on our own, we've taken initiatives to push the ball down the field. In payment, we've been talking about that. Delivery system, we've been talking about that. And employing the physicians in an integrated configuration begins to overcome some of the fragmentation. But I agree with Michael that the story has not been told yet. It's not over. And just one more point, because it does tie back to our original sort of discussion here, which is you can be higher up on the premium stream, but if the premium is inadequate, everybody loses. So right now what you're going to see as we begin to deal with the fiscal cliff, with the deficit, with the debt, is a discussion, a national discussion about who gets cut and who pays. And the last thing we want to see is the hospitals hurt and Obamacare impaired and not able to do what we were speaking to because of how that plays out.
Yes, Barry.
It's just interesting to think about it, I think, a little bit differently. There's so much attention on the Affordable Care Act, Obamacare, that people, I think, miss the fact that most of the change that's occurring in our field are being driven by business imperatives, not by legislation. You know, there's tremendous pressure from employers and then insurers and patients in general to change the way care is delivered, to reduce the cost of care. And once that pressure to reduce the costs increases, it pushes you to come up with other solutions for how to deliver care, where to deliver care, who delivers the care. But those are business pressures, totally significantly independent from
It's an interesting
government
discussion. A week ago, I did a show, and I had the executive vice president of a bank on the show, and I brought up the subject of doc in the boxes. And he was saying that under his new insurance program for the new year, that if you go to the emergency room, it's prohibitive to go to the emergency room because the insurance companies have changed it. So what effect is the changes in coverage and the fact that we've had such a proliferation of the doc in the box, or, you know, the Caremark in the CVS, or the Duane Reads, or even the freestanding locations, because you even have some freestandings. How do you look at that, Mike?
Well, I'm a strong believer that, and this is what we're trying to do in autism, is to have as broad a distribution, as broad a distribution number of sites as possible, so that people have access to care as close as they can to their home.
But I'm also saying, for another reason, many people would go to the, oh, I have a problem, I'll go to the emergency room. You know, it's their first thought of the emergency room, and in essence, it's really a flu. So why should I go to the emergency room?
That's the point I was trying to make, is that 30, 40, 50% of people who come to an emergency room probably don't need to be there. And this is an issue for us in the hospital side as well, who are running hospitals as part of larger systems. So I am all for setting up other locations, whatever you may call them, out in the communities that can adequately take care of people, including places in the Duane Reads and in the CVSs, where people can go for the basic, simple things that they don't necessarily have to go to the emergency room. We can't afford to be expanding emergency rooms to take care of people who don't need to be there. And you can have an emergency room or a variation of an emergency room, but not necessarily in a hospital. So all of these new
So my question is, what is going to be at the St. Vinny's site? Is it an ambulatory care like you're doing in the Bronx, or is it a combination ambulatory care and an emergency room?
It's a combination. Emergency room, ambulatory care, imaging center, ambulatory surgery, but no beds. Because for the bulk of the people that come to the emergency room, they don't need to be in a bed. And there is an incentive that if you have a bed next to an emergency room, you have a likelihood of putting them in a bed.
I walk around Manhattan quite a bit, and then I've noticed some signs saying that if I go to the emergency room at Lenox Hill, you don't have to wait a long time. I can't believe that. What is it? You've cut down your emergency room?
Well, no, we try to be, everybody's trying to get more efficient. Everybody's trying to get more effective. You don't want to have people wait if you possibly can. So if you are running an emergency room in a hospital, you should be doing it unbelievably efficiently. You shouldn't necessarily have to wait long periods of time. But that is not to suggest that you can't have other things out in the community. I think a lot of this stuff is good stuff. The more we can, if you look at it from the patient's point of view, forget looking at it through our lenses for a moment, because we're on the inside looking out. Look at it from the outside looking in. You're the customer out there. And if you look at that perspective, we should be providing the care closest to home, in the most convenient locations, providing good quality and a good experience. And it doesn't have to be built around hospital complexes in the future. That's an old model. That doesn't mean you won't have hospitals, but it does mean you will have a lot more other alternatives.
You an emergency?
I think one of the challenges with that, and I think that model's right, but my mother's 90 years old, and if she doesn't feel well, does she know where the right location for her to go is? You know, maybe it's more complex than and she was a nurse for 50 years. But maybe it's more complex than she realized when she left, and now she's at the back of a pharmacy, and she really needs all the support that a hospital can provide. That's why I like your model, Michael, of everything but the beds. Because the odds are that you'll be able to do just about everything necessary.
But you just opened up a 260 bed hospital with an emergency room. Why can't they have that efficient emergency room that they don't go to the beds? Which is what Mike is saying.
No, hopefully you've put in place systems that are efficient and that people get the care that they need and are discharged. Or that you're efficient enough to admit them to the hospital when it's necessary. But it's interesting when people talk about the turnaround times in the hospital and in the emergency room and the efficiency necessary to serve them properly. And then you have 100 people show up in 3 hours. So although most of the time you can take care of them responsibly in a fraction of the time, in 20 minutes before you first see them, there are times where there's this huge crush and no one wants to spend the money to build the facilities and staff them to take care of an event that happens once a year.
Now, isn't it true that, you're saying?
We see 1,000 patients a day in our emergency rooms. And I would say 50% should be there. They're elderly, or they're ill, or they have chronic illness, and they need to be evaluated in a place where if they need surgery, they need an intervention, it's there, you know. The art here is creating access for the other 50% that meets the needs of the patient, as Michael said. And I think as a community, we haven't done that well. And I'll make a point here. I think sometimes we vilify the patients when in fact they're making intelligent choices. So in the Bronx, if you're an immigrant and you don't have insurance, it's where you go. If you're a single mother and you have 4 or 5 kids, you wait to the evening when an older child is there to care for the other kids, and you bring your sick kid in. And where are you going to go? You're going to go there.
It's like I've ended up in the emergency room on a weekend, caught myself at home.
I hope you ended up the LIJ system.
Oh, sure.
Okay. So I will be back with all of you next week, and we'll get back to the emergency room. And I'd like to thank Michael Dowling, Barry Rabner, and Dr. Steve Safyer. And we'll be back next week to continue this discussion.